So, yeah. Good morning and thank you for joining today. My name is Ayan Shah. I'm a technical advisor working on the Health Policy Plus project and with Palladium. So over the next 20 minutes or so, we shall go over this technical work, which looks to explore whether provider payment mechanisms can be aligned with a rights-based approach. And let's just start off with a small poll, and let me do it the right way. I think in the front of your screens, you might see this poll pop up, which gives you three choices. The first one is just says that no, it's not possible to bring these two worlds together. The second one treads a very diplomatic line saying that, these provider payment mechanisms may have positive or negative effects. The third one takes a more optimistic approach saying that, yes, of course, with the right kind of twist, almost any provider payment mechanism can be aligned to support a rights-based approach. So let me know if you have problems with the polls. Oh, so I've got responses. Well, it's almost an even split between a more diplomatic choice and an optimistic choice. So that's a very good starting point. Thank you that there are no negative takers from this. So, okay, so this is the challenge we started with to the focus of our technical work to develop a framework which really tries to align the provider payment mechanisms with right-based approach to family planning. And when I talk about provider payment mechanisms, I'm referring to the different payment mechanisms for paying providers. And by providers, I mean any organization, institution, or can be individual like physician, nurses, community health workers, which or who are directly providing clinical services directly to the clients. So in this work, we primarily dealt with four major types of provider payment mechanisms. Line item budgeting, which, as you know, is a historical way that budgeting has taken place in mostly public institutions. Fee for service, which, as the name suggests, the provider is reimbursed for specific services at a predetermined rate. And capitation and performance-based financing, I will come to this just in a bit from now because we will take these two as examples to explore deeper into this. When I talk about the right-based approach to family planning, I'm of course referring to a very comprehensive framework that has been put forward by FP 2030, UNFPA, and the What Works Association in 2021. I will not just read through those 10 outcomes, right-based outcomes, but in the next few slides, we will try to see how capitation and then performance-based financing may or may not be influencing some of the right-based outcomes. It is important to understand here that there is no single provider payment mechanism which can influence all the 10 right-based outcomes, and then we can have mitigation measures for it. But each provider payment mechanism will end up influencing some, if not all, of these right-based outcomes. So in this next slide, okay. So the key question is, how can capitation really affect a rights-based approach? And let us consider the impact of capitation on availability, agency and autonomy, accessibility, non-discrimination, and equity. So what do we mean by capitation? Capitation is a provider payment mechanism under which a provider is given a lump sum amount per capita, a fixed amount of money, usually upfront, for that provider to provide a specific number of medical services to a specific number of enrolled individuals or clients. So that is basically capitation. So with this kind of provider payment mechanism, the question comes, does it really incentivize providers to promote some specific types of methods over others? And the clue to thinking about this is the question, what does the capitation fee cover? So let's just walk through one by one. So providers may end up having having incentive to promote less expensive short-acting methods if only those methods are covered within the capitation fee. Or just the opposite, they might have an incentive to promote the long-acting ones, like long-acting reversible contraceptives and permanent methods, if the same capitation fee is covering both the family planning method as well as maternal and child health services. So you are having the same amount of money to cater to a particular client. So you would rather offer them permanent or long-acting one in this case. And that is something which will directly go on to affect availability of a full range of FP methods. Second, over-provision of some methods over others will naturally effectively restrict both agency and autonomy of the client. Which by which I mean the non-preferred group of clients, to typically a higher level public health facility may itself create a barrier to accessing these services. And cherry picking healthier clients over, like by healthier clients, I mean clients with fewer complications, because remember, you have the same amount of fee to cover for per capita for each client. That is something that violates non-discrimination and equity. So these are just some of the ways in which we can start thinking about how a provider payment mechanism like capitation can have some completely unintentional but negative effects on right-based outcomes. And let us just take this example forward with performance-based financing. So performance-based financing, one of the most powerful health financing tools. And performance-based financing or results-based financing or pay for performance is a very umbrella term. It is something much beyond. It's a broader health financing concept. But for our purpose, let's think of it as a provider payment mechanism, which gives us the unique power to address health system objectives, because here we can pay the provider based on some measured, targeted outcomes and predetermined outcomes. So this is something which can make the provider accountable, which we can account for quality and all. But the question is, can performance-based financing affect a rights-based approach? And let's once again think about the possible effect on availability, agency autonomy, accessibility, non-discrimination, equity, and quality. And let's start with the same question. What is the design of the performance-based financing mechanism? What services or products are included in part of the incentive structure? Just like capitation, with the same logical process, the choice of which products and services are included in under the performance financing structure will directly influence the availability of a full range of methods. And something which is very unique to to PBF or performance-based financing is that very too often PBF focuses on quantity-based metrics. And unfortunately, quantity-based performance metrics only encourage providers to try and maximize client utilization, which could lead to behaviors that directly reduce client agency and autonomy. It also there is a strong motivation to select clients who are more likely to initiate family planning and focus less on clients who would require more counseling, more demand generation activities. As a result of which, this is something that can directly and negatively influence accessibility. Just like capitation, these things contribute to cherry-picking clients who are less stigmatized, or rather more likely to uptake and adhere to contraceptives. So that produces a better performance evaluation of these providers. So, for example, like married couples with children who are probably more likely to uptake and adhere to contraceptives. And this is something, this cherry picking once again violates non-discrimination and equity. And when it comes to quality, as a matter of fact, performance-based financing is perhaps the only provider payment mechanism through which we can positively influence quality of care, if and only if the incentives, the performance measured, are quality-centric and do not only prioritize volume. So I know for the shortage of time, I'm rushing through this quite difficult concepts, but the idea here is to just start a logical thinking process of how we can start thinking about any provider payment mechanism and this right-based outcome. So with this little knowledge of how capitation and performance-based financing can end up negatively impacting the right-based approach to family planning, let's think about some of the potential mitigation measures. So with capitation, so the first thing is to determine what services should be covered, because as we discussed a few seconds earlier, I think it's important to club MCH and maternal and child health and family planning services together to minimize the selective promotion of long-acting and permanent methods. So considerations like this should go in while determining what services should be covered. Then it's important to thinking about how to set appropriate rates to cover the cost, because some family planning methods obviously are more resource intensive than the other ones. Just think about intrauterine contraceptive device versus condom provision. The resource intensive, the cost is completely different. So it's very important that the capitation fee structure takes into account meeting the total cost of delivering a services. Alternatively, an alternative thought is to keep more expensive services outside the capitation structure and really think about another provider payment mechanism like a fee for service to reimburse for long-acting reversible contraceptives and permanent methods, because within the same capitation structure which caters for a lot of services, it's sometimes very difficult to account for some things which are way more resource intensive than others. So there is a thought, and it is actually quite a common thing to combine different provider payment mechanisms. Now, what about performance-based financing? So performance-based financing, once again, the same thought process that performance, the key thing lies in the design of the PVF mechanism. Performance measure, and the most important criteria here is that if performance measures can go beyond quantity and volume and can start rewarding quality and client satisfaction and include client and community feedback as part of the performance assessment, that is something which makes performance-based financing a very powerful provider payment mechanism that can be aligned with the right-based approach to family planning. But it also comes with a strong caveat, because in order to measure this performance in performance-based financing, we often need to collect data that is way beyond the routine data that is collected in the health facilities. So it is equally important that to protect client confidentiality and privacy, that this data should be de-identified in any reporting. So I think with this, we come to the end of this brief presentation. My attempt has been to just provide an example of how we can start to think about logically when we hear about a particular provider payment mechanism, how we can start the thinking process of how it can directly or indirectly, purposely or inadvertently end up influencing some of the right-based outcomes to family planning. So please feel free to ask questions, share your thoughts. There are so many cross-cutting challenges too, because these are two different worlds, and to make them interact. So we can go over this, but please feel free to join in. Yeah, please. Hi, Elaine.
Great. So I've been thinking a lot about capitation versus fee for service and continuity of care, and not focusing so much on provision of a method, but all the other kinds of services like counseling, follow-up, kind of side effect management, all these other sort of services that may not be specifically related to that method provision for, in a single visit. So how we promote, maybe multiple visits, or what would be the best way to address those issues for clients who may come and not want a method, but other services and have other needs. Over.
Okay, yeah, thank you for the question. So, the problem. Firstly, it's very difficult to directly answer that question without going into any particular country context, because when as part of this technical work, we actually did some in-country stakeholder consultations with people working in the ministries of health. So every country has their own health financing mechanism, and nobody is going to institute a particular provider payment mechanism only for family planning. So basically, family planning comes as part of a very comprehensive primary care package. And then there are these questions of, how many times, what about repeat clients, and how do you, balance between providing quality of care, because one of the measures of quality is also that your client generally doesn't have to come back frequently. They're satisfied and cured, but there are some you don't want to neglect complications and a whole sort of thing. So one of the ways to deal with this, firstly, to get down to individual problems, because there is no generic solution to this. But also, it's equally important to think about combining different provider payment mechanisms for different purposes. In many countries, typically, though the Lancet Commission on Primary Healthcare Financing came out and saying strongly favoring capitation as a population-based mechanism, but in low and low middle income countries where we work, where USAID principally focus on, it's very difficult to get capitation moving as a system because it requires enrollment and registration of patients and a whole system. So many countries still go with line item historical budgeting. And within that budgeting, it is really very difficult to address some of the quality or even right-based outcome parameters. So the key here is, I think, going down to each particular service and combining different provider mechanisms to address different goals. For example, you can probably end up having a line item budgeting with performance-based financing for a number of reproductive, maternal, neonatal, child health outcomes together, in which family planning can be clubbed, because it might be difficult to push a ministry for only having a performance-based financing solely at family planning. So I think we can begin with addressing very specific parts, but the key argument is when we start thinking about that, we often end up prioritizing quality, quantity, and volume, and not so much on quality. So I hope I answered your question. Yeah. Jay?
Thanks, Ayan. I have a quick question that, since we have Bev, we have Elaine, Pallavi, Magwa, a lot of good USAID people. So we are at the last gasp of HP Plus, and I think that this is important work. Certainly the family planning side understands the rights-based approach more than the developers of the financing schemes. And so how do we get this information out to the people to whom it is, the intended audience? Any thoughts on kind of dissemination strategically? And it's not going to happen just at the end of HP Plus, but where to start and how to capitalize. Thanks.
Right. No, thank you so much for this question, Jay. I think one of the we had primarily intended this technical brief for use by country level Ministry of Health experts and district level technical staff, but due to the dearth of evidence at the country level, people need more specific information and not very broad guidelines. So based on the stakeholder consultations we have had, I think it would be good to get involvement of the World Bank, the Global Financing Facility, and the FP 2030 Performance Monitoring and Evidence Working Group to disseminate this information. And these institutions can play a larger role towards the ultimate goal, that of the need to educate and train healthcare providers and managers on rights literacy. I guess, Jay, I'm running out of time.
Can you take Bev's question quickly? She's got her hand up.
Yes, please, Bev.
Sorry, I have yet to read this. I'd love to get it. Thank you for putting it together. I'd love to get a copy of it to really read it. There's some opportunities ahead to reach those audiences at the bank ASAP. But I wanted to hear from you with your when you were doing some of those in-depth interviews with folks at the country level. What were you hearing some of their constraints about choosing not just quantity, but quality and quantity? What did you hear from them about?
Well, Bev, thank you for your question. And it's a great question coming from you. And as we discussed previously, the one thing which we realize is a real disconnect between these two worlds, Bev. I mean, like people who are running the family planning programs, they were not so much acquainted with provider payment mechanisms, but also when it comes to right-based approach, and with all due respect, people understand quality, people understand the need. So it's on to the plenary session, I guess, but people understand quality, but if you push them further, it's when it comes to agency and autonomy, informed choice, there is a gray zone there. So I think one of the strongest recommendations we have is the need to educate and train healthcare providers and managers on both sides of the aisle about the rights literacy. Really, that is a sharp need.
I love to hear that.